Right. Good day, children. Today I'm going to teach you gynecological abdominal examination. Right. Then I will go on to teach you how to do a proper inspection of the vulva. Then how to do a proper speculum examination, and finally how to do a proper vaginal examination. Right. So now, if you look at the abdomen, as in I taught you in obstetrics, the exposure is the same up to the symphysis here and up to the cephisternum here, with the hands carefully or lying comfortably on the side. I have already obtained consent from her, and she has given us permission to do the video as well, so that we can use it in future workshops. Right. So initially, as always, it is always abdominal inspection. The principle is what? The same thing which I taught you all, is to find out whether there are any scars here and whether there is anything special that we need to see. Because in gynecology, what is very important is, in our mind, what must go on? Are there anything in the abdomen that tells me whether a future surgical intervention is going to be difficult or problematic? So actually we start planning the surgery at the time we do the inspection. Because if there is a scar here, for example a midline scar, then what it means probably is that if you are going to do a laparoscopy, right, there may be additions under that scar. So therefore we might need to go in what we call is a Palmer's point. You all understand? Further up, we might need to put in a scout telescope, a small telescope, and find out whether there are additions before putting our codes. You all understand? So inspection in a gynecologist's mind is where you start to process information and you are already thinking of a future surgical intervention. Is that clear? Right. So here, of course, she has no, when you inspect the abdomen, there are no surgical scars on the abdomen. However, if you do see these, what do you say? You might find past cesarean sections, you might find midline laparotomy scars, you might find gridine incisions for appendicectomy, you might find paramedian scars, you might find intraumbilical, supraumbilical scars in laparoscopy, you might find different incisions for other surgical procedures, you might find small lateral scars with where the ports have gone in, you might find small scar at the Palmer's point. So all these, if you do see them, then you talk about them, right? At the same time, if you find that the scars have hypertrophy or whether there are keloid formation, then of course you need to mention that as well. In this abdomen, there are no scars, right? Next thing is, you need to speak about whether there is any asymmetry, right? Probably, as I told you, it's better to say it is whether it's uniformly enlarged, whether it's not enlarged, or whether it is non-uniformly enlarged. And of course, if you see a large mass, right, you need to mention that as well, that the abdomen is non-uniformly enlarged and it is enlarged more towards the left iliac region or the right iliac region or the up to the sopra or up to the umbilicus. So you can just mention what you see for the inspection. Is that clear? So that is the inspection. The next area is that we go on to palpation in gynecology. Remember, there are 9 areas which you need to talk about. What are these? We have the suprapubic area, you have the umbilical, you have the iliac fossas. What are these? We have the, what are these areas, children? The lumbus, you have the epigastric, and you have the hypochondrial regions. Do you understand? So superficial palpation is just that, superficial palpation. And how do you do it? In gynecology, normally it is done with the right hand, right? And we follow a logical sequence. Either we go from here, covering all these 9 areas, you can go like that, or you can go like this, right? Or you can go like that, doesn't matter, but you have to follow a logical sequence. Normally, we go from where the pain is not there to where the pain is there, so that we can gently approach and the patient gets used to our palpation by the time we get to it, right? So initially we ask whether the patient has any regions where she has pain. In this patient, she has told me she has no pain, and therefore then you can start from anywhere you want. So the superficial palpation is with your whole hand. You need to use all your hand, surface of the hand on the abdomen, right? And what you do is, here I will start from this region, and then I will always be looking at the patient's face to see whether she is reacting. And it's just superficial palpation. You touch, touch, touch. So it's not, there's no pain and it is not tender. However, in superficial palpation, if you feel a mass, then what you say is, in superficial palpation, I can feel a mass which is occupying, say, the suprapubic, the left iliac fossa and the umbilical region, or whatever regions it's occupying. You just say that you feel a mass. You all understand? However, if you really feel the mass, then of course you need to go for deep palpation, and then you can describe the mass as a whole, right? Okay, next is we go for deep palpation. The principles of deep palpation in gynecology is, other than the general palpation where you do the liver, spleen, everything, which I'm not going to explain now, is we are trying to find out whether there is a mass that is coming out of the pelvis or arising from the pelvis. To do that, what we do is we approach the pelvis from above along three important lines: the midline, the mid clavicular, left mid clavicular, and the right mid clavicular line. And the palpation is always with your left. Of course, you can do it with your right, right? But for a right hander like me, the palpation will be from the left. Why? Because naturally our hand goes this way, while our right hand doesn't go that way naturally. So therefore, remember, superficial palpation, you are going this way, so it's natural. And the left hand will naturally go towards the pelvis when you are standing on the patient's right side, and therefore normally deep palpation is done with the left hand. You need to bend down a bit, right? And then what we do is, we initially start going for deep palpation all the time, looking at the patient's. So here on deep palpation, I did not feel any mass. Nothing, nothing. Then you go to the mid clavicular. So there is no tenderness on deep palpation, then I cannot feel any masses at all. And then I go to the other mid-clavicular line, and so no masses, right? So what do you say? On superficial palpation, there is no tenderness, no masses felt, and also on deep palpation, there are no masses felt and there is no tenderness. Is that clear in this patient? Of course, if you find a patient with a mass, then remember, you have to describe the mass with the characteristics that you all have learned. You have to say the approximate size of the mass, which you equal towards the gravid uterus. You say there is a mass, then you say it's occupying these regions, the suprapubic and the left and the right iliac fossas and the umbilical region. Then you talk about its size. You say, okay, it is the size of a 20-week size gravid uterus. So you equal it to a gravid uterus. So it might be 12 weeks, 14 weeks, 16 weeks, 32 weeks size of a gravid uterus. Or you can measure it and talk about it in centimeters from the symphysis pubis, just like you are measuring a pregnant uterus. Is that clear? And then you have to say what regions it occupies. Next, all the rest of the characteristics, whether it is smooth or not, whether it is whether it's tender or not, whether it is mobile, lateral, this way and that way, right, transverse model, whether it is connected to the abdomen, which you need to tense the abdomen and see whether it is going up and down, right, whether it is connected to the abdomen. Then all those you can talk about the characteristics of a mass if you do find one, right? So that is palpation. The next thing is, from palpation, what is important is, remember, the other thing is, if there is a mass from the pelvis, right, one of the things we tend to say is whether we can get under the mass. But remember, for postgraduates, even for undergraduates, there is something that you have to remember, that abdominal mass can go into the pelvis. So actually you cannot get under it over the symphysis pubis. Do you understand? And also a pelvic mass can go into the abdomen. Then also you cannot get under it. So exclusively saying that I can get under the mass and therefore it is maybe not a pelvic mass, so I cannot get under the mass, so therefore it is a abdominal mass, is not really very good thing to say, and maybe not logical. Why? Even a pelvic mass, which may be a pedunculated fibroid, you might find it in the abdomen, right? Or an abdominal mass like a mesenteric cyst, or any sort of mass that is arising from the bowel might slowly go back into the pelvis, and you can palpate it like a pelvic mass. Do you understand? So to say that I cannot get under the mass and therefore it is a pelvic mass may not be applicable to every situation. That it's very important for you to understand, right? But however, you can say I cannot get under the mass, so most probably it might be a pelvic mass. But also, if you are asked, you can say, okay, it might also be an abdominal mass which is going into the pelvis. Is that clear? Right. So that is palpation. The next part is percussion, right? Now, why do we percuss? To find out whether there is fluid, or we percuss over the mass to find out how it sounds like, right? So you can percuss over the mass, you can find it dull, you might find it very rarely resonant, right? And of course, you can elicit a fluid thrill by keeping your hand there and giving a tap, and if there's fluid inside, it will conduct the sound and you can feel it on your hand. So that is one thing. The other thing is, if you want to find out whether there's free fluid, right? What you do is, if the mass ends here, so you percuss, and then you go slightly above where there is no mass, then you go down vertically like that, right? So then what you do is, if there is dullness or flank dullness, there's a possibility there might be fluid or ascites. It may be blood, it may be ascites, right? Once you find where it's dull, you can either ask the patient to turn towards that side. So what happens? Then the fluid from here also fills up, and the dullness will shift upwards. So it's shifting dullness, but it's going to shift upwards. The other way around is, while you keep your hand on where it is dull and you ask the patient to turn towards your side, then the dullness will go off because the fluid is going to shift. So it is also shifting, but the other way. You all understand? So you can use both, it doesn't really matter, and that is how we use shift in dullness to find out whether there is fluid in the abdomen. Is that clear? So that is basically all what we do in a gynecological abdominal examination. Remember, in your general examination, yes, you should have palpated the kidneys, you should have palpated the liver, and then this is a specific gynecological abdominal examination which you need to be very thorough with. Is that clear? Right. So next we are going to shift to the inspection of the vulva, right?